Good day, everyone. Today, I welcome you to the second ASPA FLEX webinar, which is the current and future state of patient safety. What have we learned? Now, we remember that the most important contribution of anesthesiology to patient safety may be institutionalizing or legitimizing patient safety as a topic of professional concern. The various safety advances that have been made in anesthesiology are essential to model for the rest of healthcare. Still, they remain a work in progress and will require a long-term commitment to achieve their full promise. As anesthesiologists, we should continually and forever reduce patient harm by wholeheartedly embracing an ethic of learning. Again, this will only be achieved with hard work, and truly, the price of patient safety is eternal vigilance. Good day again. I am your lead for this webinar. My name is Arlinda, and I would like to go on and show you what we have for you today. Our program will consist of, first, having our speaker's introduction, of course, before every talk. We will have our topics for today: the anesthesiologist as patient safety officer, critical incident reporting, the importance of institution reporting and analysis, and accreditation and accountability. After which, we will have our Q&A session. Now, in the Q&A session, please remember that you can send in your questions and comments via the Q&A section at the bottom of your screen. The chat and raise hand functions are disabled, so you have to write down your questions. Our moderators will highlight your questions and give them to the appropriate speaker during the panel discussion. Some questions will be answered by text by the appropriate speakers in the Q&A section. With regards to your certificate of attendance, please know that this will be automatically generated and forwarded to those who will submit the post-webinar survey. And this post-webinar survey will only be emailed tomorrow, February 20 at 1700 hours Singapore time. Please ensure that you have correctly keyed in your full name and your email address. If you have been unable to finish the webinar and you would like to view it again, please visit our website at aspa-2000.com or on Facebook or on YouTube. You will find us there too. After a while, we are going to show you some poll questions too. When the poll is launched, you will be prompted to answer the polling questions. You will have 30 seconds to respond and submit your answer. We will, of course, share the results soon after we end the poll. Please remember that after the result is shared, you may please close the poll so that you can see if there is a slide shared by our speakers, or you can visualize our speakers as well. So may I now introduce to you my dear friend and esteemed colleague, Professor Rebecca Jacob. She was also formerly the head of the Department of Anesthesia at the Christian Medical College Hospital in Vellore. She was past president of the ASPA, the Indian Association of Paediatric Anesthesiologists, the Research Society of Anesthesia and Clinical Pharmacology, the Indian Association of Cardiovascular and Thoracic Anesthesia, and she has also chaired the Pediatric Committee of the WFSA. Take it away, Rebecca.
Thank you, Linda. Now we go on to the education part. I would first like to present a critical incident report. This is theoretical, but we would like you to think about it as we go along today. A 10-year-old boy, 40 kilograms in weight, is coming for elective tonsillectomy and adenoidectomy. He was admitted the day before surgery, reassessed by both the surgical and the anesthesia team, and noted fit to go through the scheduled surgery. He has a history of recurrent tonsillitis, allergic rhinitis, and mild obstructive sleep apnea. On the day of surgery, the anesthesia team prepared medications before bringing the patient in. The propofol and atrocurium were drawn for induction, while fentanyl, dexamethasone, and ondansetron vials were kept aside on the anesthesia tray to be drawn later. The anesthesia induction was smooth with no issues. The senior anesthetist took care of the airway, while the junior inserted the IV and gave the medications. When the senior anesthetist was about to draw the fentanyl, he noted that the fentanyl vial was empty and the ondansetron vial was not yet opened. It was next to a broken vial of fentanyl. After verification, the junior anesthetist stated that he gave the fentanyl 100 micrograms in the 2 ml, mistakenly thinking it was ondansetron, which is 4 milligrams in 2 ml. The surgery went well. There was about 20% drop in blood pressure and heart rate after the 100 micrograms of fentanyl. This was noted and managed diligently by the team. Now, we'll go on to the rest of our talks. Our first speaker is Dr. Angelina Gapay. She's the chair, Department of Anesthesiology, Divine Word Hospital, Tacloban City, the Philippines. She's the patient safety officer of the same hospital and is a member of Professional Wellbeing Committee of the WFSA. Over to you, Angie.
First of all, I would like to thank ASPA for this opportunity to participate in the patient safety movement. This talk will touch on the qualities of the patient safety officer, the needs of the position, and the duties of the anesthesia patient safety officer. Healthcare is complex. The advancing scope of procedures and technology in surgery and anesthesia adds to the complexity of healthcare and may contribute to patient harm. Adverse events remain frequent and may be preventable in over 50% of cases. However, anesthesiologists are risk-averse, and because they are at the center of the perioperative care, are interested in and make contributions to patient safety and better outcomes. Anesthesiology is acknowledged as the leading medical specialty in addressing patient safety. With that background, would an anesthesiologist be a good choice for a patient safety officer? What are the qualities of a patient safety officer? He or she should have the ability to identify existing and predictable safety threats, the authority to take prompt corrective measures to eliminate these threats, and the ability to solve or resolve problems. The anesthesiologist who has the specialization, extensive knowledge, training, and experience would fit these qualifications. Although a desirable qualification would include a remarkable education in safety science, an unwavering interest in patient safety and willingness to obtain the needed training would suffice. A senior level position working with both administrative and clinical leaders would be a plus factor. Before accepting the role of the patient safety officer, an anesthesiologist must envision the needs of the role, because he must have dedicated time distinct from clinical duties of providing anesthesia. Because safety-related work is real work and not additional work as assigned. The amount of non-clinical time will depend on the size of the department, anesthesia subspecialties practiced, the maturity of existing safety program, and the duties expected of the position. Time needed to investigate adverse events promptly and react quickly to threats to prevent harm would require about 2 to 3 days per month. Funding to support the non-clinical time for the role of the PSO should come not from within the department, but from the hospital or university level. The PSO has value across the whole organization and not just the department. However, if there is a need for funding for increase in staffing, the funds may come from the department budget. But for funding for equipment, it should be borne by the organization. Interventions needing support for funds would include for standardization or simplification of processes, creation and use of checklists and cognitive aids, creation of barriers and recoveries to prevent errors from reaching the patient. Assuming the role of the patient safety officer begins with needs assessment to identify the gaps that exist between the current state and the desired state. Audits be conducted to ensure that the current safety practices are still in place and being followed. Assessing the safety culture of the department is very important. The most commonly used safety culture survey is from the AHRQ, or the Agency for Healthcare Research and Quality. However, if you need an anesthesia-specific survey, there is the Patient Safety Climate in Anesthesia. The PSO can use the sample audit questions for established safety practices. For instance, for M&M or conferences, sample audit questions may be: do they focus on the process involved and not the people involved? Do they address events that had potential to harm and not just the ones that resulted in harm? For safety checklists, is every element done every time? Are they being led by the correct person at the correct time? Is anyone in the room focused or participating? For crisis manuals used in the intraoperative period, are they available in every anesthetizing location? Are they available in print and electronic forms? Are they included in this do OR simulations conducted on critical events include the importance of using them? Are they being used in practice? And for root cause analysis, are they being conducted in accordance with best practices? Are corrective actions from previous RCA still in effect? So these are the sample audit questions that the anesthesia patient safety officer can use. The suggested duties of the anesthesia patient safety officer would include to investigate perioperative adverse effects and near-miss events, to participate in root cause analysis of perioperative events, to devise effective and sustainable solutions to safety threats affecting perioperative patients, and to regularly assess previously implemented solutions to ensure they are still functioning. Others include to engage in the safety education of medical and nursing staff and trainees, and to contribute to the field of patient safety science through attending and participating in patient safety conferences and publishing experiences, challenges, and best practices. The PSO should also collaborate on solving safety challenges with departments that affect perioperative patient care, and this include perioperative nursing, pharmacy, the departments of surgery and OBGYN, the laboratory, the blood bank, and IT. He is also the liaison officer between the Department of Anesthesiology and hospital leadership, including the chief medical officer, directors of patient quality, patient experience, risk management, and legal affairs. He should conduct regular safety needs assessment based on event reporting, soliciting input from the department members, the accreditation and regulatory bodies, and then implement corrective plans. Collaborate within the department with leaders in areas that have significant overlap with patient safety, including equipment, evaluation and purchasing, clinical competency, and education. So, our take-home message is that the anesthesiologist, the successful anesthesiologist, anticipates and prepares for when things do not go as expected. That is when the routine operation becomes complicated. As a successful patient safety officer, he or she will be no different. In the operating room, we anesthesiologists manage unanticipated events based on medical science, and so must the PSO. We should consider safety as a science, so we must study safety with the same fervor and enthusiasm as we do physiology and pharmacology. Safety entails study of systems design and how they apply to technical work and teamwork, remembering that healthcare is a team effort. By doing so, we as anesthesiologists continue our legacy as forerunners in patient safety. Thank you for your attention.
Thank you, Angie. That's given us food for thought. Our next speaker is Dr. Arif Marsaban. He's a senior consultant, Department of Anesthesiology and Intensive Therapy Faculty of Medicine, University of Indonesia, Dr. Sipto Mangankusuma General Hospital. He's a member of the Board of Supervisor and Advocacy of the Indian Society of Anesthesiology and Intensive Therapy Chapter from Jakarta. Formerly, he was chairman of the Indonesian Society of Anesthesiology and Intensive Therapy Chapter, Jakarta, and vice chairman of the Indonesian Society of Anesthesiology and Intensive Therapy. Over to you, Arif.
Thank you, Prof. Rebecca, for the introduction. And to all participants, thank you for joining the patient safety webinar. My talk will be about the basics and principles of incidence reporting, which of course is the first step in the process of improvement in healthcare. My talk will consist about creating a positive environment to motivate incidence reporting, the importance of reporting, the definition of incidents or events, the reporting methods and structured form, and the WHO conceptual framework for incident reporting. This is a good quote from Kohn in the book Air is Human. The biggest challenge to moving forward a safer health system is changing the culture from one of blaming individuals for errors to one which errors are treated not as personal failures, but as opportunities to improve the system and prevent harm. In healthcare services, we always try to improve the quality of healthcare. And one important step in this process is to reduce the risk of complication or adverse events. To do this, we should always learn from the things that went wrong. And this led to the establishment of patient safety incidents reporting in our health care facilities or institution. So the first important step in this system is the reporting from our staff. To motivate our staff to voluntarily and immediately report every incident that occurred, there should be a positive environment that supports the staff. The hospital administrator should eliminate the blame culture and encourage blame-free reporting. And this will motivate staff to report every incident, even the minor incidents or near misses. Therefore, hospital and healthcare institutions should prioritize incidents reporting. Also, healthcare institutions should create environment that provides a reporting system that is user-friendly. because some staff may not be familiar with ITs or technology information. Administrators should always provide information on the progress of the investigation and on what the action plan will be taken. Always show also that improvement in safety is consistently made by learning from errors that had occurred. As for the role of hospital staff in reporting, staff should have an allocated time to make a report. The staff should have knowledge on what to report and the clarity of the report. The aim of reporting and the importance of incidents reporting are public accountability. It's the healthcare institution responsibility to the public in the quality of the healthcare. Also, a response to the patients and families that are involved. So the patient and families are informed of the follow-up of their incident. Also, it's a communication route, a system that provides immediate communication to all, especially to the administrator. Also, it's a barometer for risk within healthcare to know the level of risk in our healthcare institution. And last, as a foundation for learning improvement to learn from mistakes and wrongdoing. What is an incident? The institution should have a clear policy how incidents are defined or recognized, and this should be aware by all our staff. So identifying and recording an incident is the very first step in a reporting and learning process. This is the WHO patient safety incidents. And in incidents that did not reach the patient but may cause harm if it was not aborted or prevented prior to its administration is called near miss. This is near miss. For example, a wrong jab was about to be given but was noticed prior to the injection. Near miss events are considered the most important event that we could learn from, because we could learn what action was done that prevent this occurrence, this event, became harmful. As for harmful incidents, it is an incident or event that reaches the patient and cause harmful or injury to the patient. Harmful incidents may be preventable, known as also as adverse events, or unpreventable adverse reaction. Example of preventable incidents is wrong side surgery. Unpreventable incidents is a justified or a correct action where the correct process was followed by a harmful event such as an allergic or anaphylactic reaction to anesthetic drug. Other terminologies of incidents or events is sentinel, an unexpected occurrence involving death or serious physical or psychological injury. Never events are defined as serious, largely preventable patient safety incidents that should not occur if relevant preventive measures have been put in place. For example, wrong side surgery. Potential harmful event is a condition or situation that potentially may cause harm, but no incidents have not yet occurred. Example, storing laser drugs in the same place. Reporting incidents or how to report an incident. We make sure the accuracy, the quality, and the completeness of the report. Provide as much detail as possible. Provide objective and factual information. Report as soon as possible, at least within 24 hours of the incident, so that we won't forget the details. And where possible, avoid identifiable details such as staff name, so to keep it neutral. Methods of reporting: a simple paper form, and then transferred to electronic record by administrator, or the staff directly input the report in an electronic report. Most of us already have an electronic report system, but in my place, it's not always available or provided. This is a sample of a reporting system by WHO, minimal information model for patient safety reporting and learning system. It is divided in two parts: the structure part, The structured part consists of patient information like age, sex, the time of the incidents, and the location of the incidents, agents that were involved, suspect cause, contributing factor, mitigating factors, the type of incident, the outcome of the incident, and what action was done, what the resulting action, and what the reporter's role. And the second text, that is a detailed written report of the incident or the chronologies of the event. This is a clinical framework of incident reporting as a pyramid. The first step is incident reporting, and this is done by the staff. The next step is the assessment of the reporting and the investigation of the causal of the incidents, which is done by the team investigator. And the next step is system insight and action plan. What has been detected and what action has taken to improve the situation, and this is done by the hospital administrator. And at the top is future harm prevented. And this is done by making new regulation, new policies that can prevent future harm of the same incidents. As a summary, incident reporting are valuable information that improve the quality of health services, create a non-blaming culture environment for healthcare professionals to make incident report voluntarily, provide a user-friendly reporting system, and as the final objective is to prevent further harm in the future with new policy or regulation. So this is the end of my talk. Thank you for your attention. Hope you have more knowledge in this aspect of incident reporting. Thank you.
Thank you, Dr. Arif. That was very interesting, and we hope more of us will be able to discuss with each other during the panel discussion a bit more about critical incident reporting. Now we go from Indonesia to Singapore, to Dr. Xiao. He's the head and senior consultant, Department of Pediatric Anesthesia, KK Women's and Children's Hospital, Singapore. He's the deputy vice chair for clinical safety and quality, academic clinical program, ACP, anesthesiology and perioperative sciences, Sing Health. He's the chair of the pain committee of the KK Women's and Children's Hospital. Over to you, Dr. Xiao.
Thank you, Rebecca. Just let me share my screen. Okay, thank you very much. Thank you, Dr. Arif, for giving us a lecture on the principles of critical incident reporting systems. And the report of adverse events and the analysis and implementations of the risk control plans exist in most departments and institutions at various levels of complexity and maturity. Our department we have a critical incident report system for many years. And over the years, we have learned many things through the analysis and actions for these incidents. But we have also seen that some problems continue to repeat itself, and often it seems that many lessons are not learned. And so therefore, we want to continue this talk by speaking on how we approach patient safety incident reporting system by using a system approach. And I would like to share with you our incident reporting system, what are some of the lessons we learned and also some of the challenges that we faced, and to then discuss maybe what is in the future of these reporting systems. So I think the first thing to start off with is the idea of a system approach, and that healthcare and indeed even the incident reporting system that we are creating have a complex nature. It's a complex adaptive systems, which means that there's multiple components with complex interdependence. There's ability to learn and also to adapt over time. And it's very evident to us that change is very resource intensive and often very slow. And so therefore, it's very important to have and useful to have a kind of framework to help us to articulate all of these complexities, but also to operationalize how we're going to build the system and use it to get the desired outcome that we want. So this is a framework among many that you can reference, and we adopted this from the National Health Group in Singapore. And it kind of composed of 5 main components, which is interrelated and needs to be worked on and built on for the whole system to work. I'll briefly bring you through them. So the first thing is about detection. So this is where incident reporting is, to really detect performance data, incidents of the system that you're currently having. So it could be outcomes that are mild or outcomes that you're tracking, and it could be near misses, like what we said previously, where harm have not reached the patient. And then as you go further in the severity range, then you have adverse events and then severe reported events. So incident report is just one of those methods, retrospective methods. It has some well-known limits, like the underreporting, reporter bias, for example. But nonetheless, it offers unique and important opportunities, like a window to peer into your system. And that's how we should see them, as they are merely opportunities for us to examine our systems. And of course, the analysis is the important part. And analysis techniques such as root cause analysis to establish a causal relationship as to why things happened and what are the conditions that enable that to happen. It's important to then allow us to formulate effective improvement strategies, which will involve various processes such as redesign, clinical innovation, etc. We need to remember that all of this has to be supported by the correct culture, like we talked about earlier on, for reporting, and also rigorous change management abilities. It's very important for us to monitor and evaluate the change that we are designing to see whether it is giving us the effects, the outcome that we want. And it's very important also to have an overarching governance structure to make sure these things are in place and working and giving results. So let me share with you our department's system. What do we do? I think it's important to have good definitions. We started with something quite general. So we use this as any event that did or had the potential to negatively impact the quality of the care of the patient. We started with something quite general so as to allow us to encompass the whole range of incidents that could be reported to offer us teachable moments. I bracket negatively because we also understand things that could positively impact the quality of care of the patient are also very important and worth reporting. But we did find that it was important to be very specific, so we have specific guidelines as to what should be reported. Near misses are encouraged. Anything that had sustained physiological derangement like desaturations or cardiovascular instability, harm, injury sustained, which includes pain or psychological pain, harm. Medication errors are mandated to be reported. Equipment issues, procedural complications, escalation of care monitoring, as well as any management incidents that we could report and examine. We started with a paper form that was about 20 over years ago, and the paper form allows us to notate various information as well as to write down a narrative. So when we started, we wanted to capture demographic data. This could nowadays be captured through your electronic medical record systems or anesthesia information systems if you have them in your departments or institution. We also captured anesthesia management information if there was a need to causally relate incidents with, any relationships that bears with your intraoperative anesthesia management. We also have categorization of the incidents to allow us to, at the point of entry, categorize this and give some guidance as to what kind of things we want to be reported. But the next page is where the most important things are written. So this is the narrative, right? The narrative which offers a lot of details, a lot of opportunities for analysis. We gave a kind of guidance as to how they should write it, what happened, how is it detected, what are some of the contributing factors, any preventative ideas, and the outcome of the patient involved with that incident, to hopefully guide the reporter to something that is going to be useful. So all this information is collated and then added into a database. Increasingly, we find that it is important and necessary to adapt the form that we fill, because to include and benefit different kinds and categories of events, we have used cloud-based platforms to allow people to surface reports on pain services during requests for difficult intravenous access, as well as other workflows, consent fasting, handover related issues that may not happen in the theater, right? So all this information is collated for regular reviews. Now, what do we do for analysis? We have a department safety officer who is in charge of the critical incident database. And we typically would then collate the incidents to be discussed at department incident reporting sessions. Where it is beneficial and necessary, we will escalate or surface different kinds of incidents to the various domain work groups, experts in our department for further comments, analysis, and sometimes ideas for change. And when there is serious reportable events, we would, or for example, a code blue situation, we would convene a multidisciplinary medical review to discuss that. And when we do notice that there is a collection categories or patterns in the incidents that we report, then we may conduct a thematic reviews to examine that particular topic. So this is an example of what we mean by different domain experts for their analysis. We have people working in medication safety, resource code, pain service, airway experts, cardiac, equipment, workflow, etc. And so some of the techniques that is used for the analysis, these are the well-known root cause analysis. And there are certain limitations to root cause analysis in the sense that sometimes it does not really reflect the multidimensional and multifactorial nature of factors that in the system that needs to be looked at. A fishbone diagram like this may be more representative of the multiple factors that has to be looked at. And in certain cases, we find it useful to adopt other frameworks. So one of these framework is the HFAC, the Human Factor Analysis and Classification framework, where we look at organizational influences, supervisory factors, whether there were preconditions for unsafe acts, and when there are unsafe acts, whether errors, violation in the different categories of factors, to allow us to have a more complete holistic assessment of the system, so that we could then craft what is the necessary or multiple necessary actions. So another system from NHS is this system engineering initiative for patient safety framework. Again, it talks about the complex system where work happens and the person and personal behaviors are surrounded by technological tools, organizational, environmental, and task-based influence that needs to work through processes to arrive at outcomes. So those of you who are interested in looking at these various frameworks could take this code and get a reference for yourself. So the goal of analysis is really to come up with ideas for interventions, right? So they are sometimes necessary to have different categories of interventions versus just one intervention. So there could be organizational, environmental change, standardization to reduce variation, clinical innovation, and so forth. Often it requires process redesigned and if necessary, a QI project or additional audits to enact improvement. So what did we learn from collecting all this? We very early on published a few papers looking at the audits of this incidents, right? And what we did find was largely comparable to a lot of large-scale incident reporting series that has been published and has been published since. So we know that the incidents in various age groups, we know the risk factors involved. It is well known and correlated that infants and neonates have higher risk, and premature infants ex-prem has higher risk as well. This has led to differences in, interventions in terms of training with regards to these specific age groups. We also learned about the different categories, which has been also noted to be consistent across many different series. And notably here, it is in general agreement that respiratory events are most common, but also very importantly up there are pharmacological medication error-related incidents. So I want to talk about just medication safety as an example of the multifactorial nature of the problem and the kind of implementation that needs to be done. So when we tackle medication errors, very often we need to work on simultaneously the different parts of the medication delivery system. We need to work on the people, the training, the communications, the incident reporting, and forming the necessary committees to look at this. And we also had to do work on medication handling, storage, the way we prescribe, and the way order sets and electronic medical records are used, as well as the way we prepare and administer the drugs in terms of label designs, drug calculators, standardization, and as well as double checking behaviors, right? Now, I want to share with you this project that we did with regards to hypothermia to illustrate the point that from a singular or a few incidents of a certain kind generates necessary many kind of activities to allow us to then track and then get the improvement that is necessary. So this thing is, well, we started with a hypothermia audit in 15, and very soon we realized that the rate of hypothermic patients is actually quite high, and we started to make mandatory measurements of temperature on arrival at PACU, as well as intraoperative measurements, and we fed this information back to the individual practitioner on a regular basis, just to allow them to know what is the rate that in their practice of hypothermic patients, as well as the list of hypothermic patients with the details, so that they could calibrate their clinical practice accordingly. And we found that we were able to reduce that to less than 10%. And as we continue to monitor and use the data points in the run chart, we had other research projects that's related to hypothermia. We have guidelines that is in place, and we also had the funded availability of new monitors to allow people to monitor their patients more effectively. And we found that all of this has actually allowed us to attain a sustained improvement in a low rate of intraoperative hypothermia. And lastly, on the third example, I want to share with you an example where we had multiple types of incidents reported: hypothermic patients, patients with iatrogenic injuries, medication errors relatable to a particular type of surgeries. And then we embarked on a quality improvement project on patients undergoing scoliosis surgeries. And over the course of several years, we managed to, using very rigorous quality improvement methodologies, to get improvement in significant areas like morphine usage, intraoperative inter-hospital stay, days on the pain service, reduction of harm in terms of drug errors, iatrogenic injuries, as well as achieve standardization of protocols. So what are the challenges that we have faced and we noticed? And I believe it's not uncommon. I think the expertise for good analysis and ideas for improvement is important, but it needs to be built with training and it requires experience. And often things that we need to do is very resource intensive, right? And the risk control and the implementation design sometimes may not be ideal or may not be well designed, and that may lead to failure to get the improvement that is required. The implementation is often difficult, and the evaluation of the effectiveness of the implementation is often not done. And there may be sometimes lack of feedback loop to encourage learning, and often learning is not spread within and across institutions. So you find that people are relearning the same incidents and having the same problems. What do we think are some of the possible solutions? First, it's important to prioritize and resource an effective patient safety incident response system. There should be adequate training, resource, time given, as what Dr. Gape has alluded to. There should be very clear policies and clarity in the methodology and the infrastructure of responsibilities and how a patient safety response system should work. We should aggregate learning within and across institutions based on what we have learned from this analysis of the incidents. But we should also not just talk about incidents, but also talk about the solutions and how effective those solutions are, so that people do not need to relearn or reinvent the view. There are also several databases and registries that exist in various departments, countries, and even regions. And this can serve as great learning platforms and also collaborative platforms to allow ideas to scale and spread. An example is the Wake Up Safe, a North American platform of sharing pediatric anesthetic incidents and the analysis, as well as ideas for improvement. So in UK, the National Audit Project is well known, where they do a thematic analysis on various important aspects of anesthetic complications to give guidelines, ideas for change. So in summary, I want to end by just saying that it's very important to have a system-based approach to patient safety event reporting and response. Incident reporting needs to be coupled to robust quality improvement process to effect sustainable change. And lastly, safety incident databases can be valuable sources of safety information, as well as collaborative platforms. Thank you very much.
Thank you, Dr. Yuna. Xiao, both Dr. Arif and Dr. Xiao have told us how reporting of adverse events and critical incident reporting will improve the quality of care for our little patients. However, I'd like both of them to think about the problems some of us in different countries have, where people are afraid to report because they're afraid it's going to be a witch hunt, or whether there are going to be legal implications to what they have reported. Think about it. We will talk about it in the question and answer session. The next speaker is Dr. Baljit Singh. He's professor and head of anesthesiology, Faculty of Medicine and Health Sciences, SGT University, Gurugram, India. Over to you, Baljit.
Good afternoon. Thanks, Dr. Rebecca, for your kind words. And first of all, I would like to thank ASPA for giving me the opportunity to share the stage with learned faculty from other countries. And coming to the topic, accreditation and accountability, when this topic was allotted to me, although we use the term accreditation quite frequently, but I just wanted to know the exact meaning. So when I looked up the Oxford Dictionary, what I learned was that accreditation is the action or process of officially recognizing someone as having a particular status or being qualified to perform a particular activity. When we translate this accreditation to healthcare, it actually means an external peer review process used by healthcare organizations to accurately assess their level of performance in relation to established standards and to implement ways to continuously improve the healthcare system. Now, there's a definition which is given by the International Society for Quality in Healthcare, and it states that accreditation is the public recognition by a healthcare accreditation body of the achievement of accreditation standards by a healthcare organization, demonstrated through an independent external peer assessment of that organization's level of performance in relation to the standards. Now, quite often the two terminologies, accreditation and certification, they coexist, and quite often it is used interchangeably also. Although they both belong to to the same category, but there is some subtle difference between the two of them. Certification is used for verifying. It is attestation by a third party, and this is in relation to the processes or the systems that a specified criterion of quality or standard has been achieved. It's not just granted to institutes or bodies, but to individuals also. Like we have board certified endocrinologists, board certified endoscopists, board certified ultrasonologists, like that. Now, accreditation provides visible commitment to improve quality of care by ensuring a safe environment and to reduce the risks to the patients and to the healthcare workers during the patient care delivery. It has gained worldwide attention as an effective quality evaluation and management tool also. The focus of accreditation mainly is on continuous improvement in organizational and clinical performance, reducing inadvertent harms that are often seen in healthcare system, learning and improvising, self-development. It's not just achieving certificate or an award, or merely assuring that there is compliance with minimal acceptable standards by that hospital. Now, do we need accreditation? We need, because it ensures quality. How? By observing the process of healthcare delivery, appropriate use of the available technologies, and integration of the knowledge for optimal use of resources. And once the quality is assured, it helps in the cost containment and accountability of the individuals as well as the system. And there are reduced errors. Once the errors are reduced, there is increased safety, which is brought about in the system. And when the public recognizes that this particular institution observes certain standards, it attracts more patients. And when it attracts more patients, well, the reputation of the healthcare institution goes up. The healthcare institution also is happy because it brings more money for that. There are major accreditation organizations. One of them, Joint Commission International, is very well recognized. It's based in US. And in India, we have the National Accreditation Board of Hospitals and Healthcare Providers. Now, International Society for Quality in Healthcare is the umbrella organization which further accredits these bodies like JCI, that's Joint Commission International in the US, Accreditation Canada International, and Accreditation Organization in UK and Australia. Now, what are the key elements of accreditation? One, it's a standard setting process. You set standards and then you achieve meet those challenges. There is external evaluation of compliance against the set standards. There is governance of or a stewardship function, a remediation of or improvement process following the review, promotion of continuous quality improvement, and it works with a very simple principle of safety first and innovation always. Are there benefits? Yes, there are many. One is foremost is the consumer confidence. When the patient comes to the hospital, he feels that he is in good hand because the hospital observes certain standards. The second is the workforce. It attracts high quality staff by commitment to the quality of patient care. The next is the risk management. There is understanding of the risks and how to mitigate those. That is in place. Innovation, the hospital uses quality improvement to do better and better, and excellence to reach the full potential through continuous improvement in the system. There are other benefits too. One, there's benchmarking the best in the business. I mean, a hospital, whether it's in India or in Philippines or in Malaysia, it is comparable to the services that are provided in US or UK or wherever. There is continuous commitment to quality, and that drives efficiency. There is enhanced image and recognition. It builds trust and relationship, which is very important. It increases profitability also because there are more number of patients that the hospital can treat. There is organizational improvement and there is a competitive advantage as well. Now, accreditation is, there's a lot of awareness about accreditation in the last decade or two. And there is so much awareness now that there is a World Accreditation Day also. 9th June is observed as the World Accreditation Day, just like we have World Anesthesia Day, we have World Restart a Heart Day. So 9th June is a day for the World Accreditation, and the first time it was started in 2008, and every year it is celebrated with major conferences, events, and workshops that take place in nearly more than 90 countries. Now, coming to accreditation in low-income countries, like in Asia, we have there are many low and middle-income countries which are pursuing healthcare reforms to achieve universal healthcare coverage. But the gaps in healthcare quality, they threaten this objective of achieving this universal health coverage. Despite serious resource limitations, there is a growing belief that strengthening healthcare quality can have an important impact on efficiency, security, and responsiveness of health services. And it supports expansion efforts towards the goal of achieving universal health coverage. Mathia et al., they opine that the true goal of universal health coverage scheme is to provide universal access to high quality healthcare services, and this can only be realized if quality enhancing mechanisms like accreditation can be successfully implemented in LMIC setting, that is low and middle income countries. The benefits of accreditation, just to give an example of our own hospital. Our hospital got accredited about a year back. What I saw was that now there is continuity of care, smooth, seamless continuity of care from one place to another. There is handover and there is takeover. Major benefit of accreditation has been the documentation. Tremendous improvement in documentation. Every drug given, any action taken is documented. It is signed, and signed, the signatures are legible. It's either stamped or written in capital. There is date and time, which always is put on whenever there is an entry made in the case sheet. This management of medication and reconciliation of medication whenever there is transfer of the patient from one facility to another. Hospital infection control is another major gain that I've seen that has happened because of hospital accreditation. There is improvement in response to code drills. It is, for code blue drills, we have just about 2 minutes of response time. That's a big improvement, following NABH. There is incident reporting and root cause analysis. There are anonymous boxes which are put up in the hospital. So whenever there is an incident that is happening, so just to maintain anonymity, there is information on a paper that is put in. It's taken out every week. It is analyzed, and then corrective steps are taken. And the culture of no blame and shame, it now prevails. Blame and shame doesn't really work, because if you blame a person, he will stop working over a period of time, because if he doesn't work, there is no possibility of the mistakes occurring. So he would be considered a safe man. So blaming and shaming is rather counterproductive to the objective. Now, having said about accreditation, now let's come to accountability. Accountability is the obligation of an individual or an organization to account for its activities, accept responsibility for them, disclose the results in a transparent manner, and it also includes responsibility for money or other entrusted property. It's Mahatma Gandhi, who was considered the father of nation in India. He said that it is wrong to seek to escape the consequences of one's acts. And Stephen Covey stated that accountability breeds responsibility. Not only responsibility, but responsibility. There is a difference between the two. Now, responsibility and accountability, again, are these two terms which are quite often and very commonly used, sometimes interchangeably also. But responsibility may be bestowed, accountability must be taken. Responsibilities can be given, but that doesn't automatically guarantee that personal accountability will be taken. It is possible to bear responsibility for something or someone and still lack accountability. Now, when it comes to accountability, one must know what's your role, what's his role, and know what is expected of you in that position. Own your role. Take ownership of your assignment. Take ownership of all the actions that you perform. Be committed. When you say you're going to do it, do it. Don't delay, and don't keep on postpone unnecessarily. Don't procrastinate. Prioritize and finish your assignments in a timely manner. Be honest, acknowledge mistakes, and do your best to fix them. If you need help, ask for it. Apologize in case you have fallen short of your objective, admit it. And don't forget to say sorry to the organization. Importance of accountability is in building trust, and building trust is essential in any relationship. It improves performance by eliminating time and effort on distracting activities and unproductive behavior which may be associated with this. It promotes ownership. It's an effective way of teaching the value of work to the healthcare worker. It inspires confidence as well. You can increase your team members' skill and confidence with accountability. Now, accountability builds trust, as I said, inspires confidence, it promotes ownership, and it improves performance of the healthcare worker. It leads to team bonding. Your choices and actions are recorded and they are accountable, and it leads to responsibility in that healthcare individual also. When we talk about accountability, we must set goals. That what do you expect from yourself and how to improve yourself. Seek opportunities for improvement of your action, and that's the only way you can reach your full potential. You must measure performance. It is stated that when performance is measured, performance improves. When performance is measured and reported, the rate of improvement accelerates. In healthcare, accountability ownership is not an option. It is a necessity. It is a necessity because we are dealing with lives. Small action or inaction on our part can lead to very serious consequences. And that's where we must have a team formation where there is accountability for each person and one can stand for another in case there is need. To summarize, healthcare professionals are responsible for treatment, care, and safe clinical outcome of the patients. Personal accountability is important. Any weak link in the chain of care of the patient can be risky and can lead to untoward incidents. There is need to identify areas which are prone to errors so that we can prevent the adverse events from happening. Adopt proactive intervention of a systems approach, not a personal approach. Maintain a safe working environment so that there are less errors during the patient care delivery, and respond appropriately to concerns from patients and from your colleagues. Thank you so much for your patient hearing. Over to you, Dr. Rebecca.
Thank you, Dr. Baljit. That was really something to think about.
Thank you.
We now go on to a poll question, which Dr. Baljit would really like you to answer. You have 30 seconds to answer this poll question.
Well, yes. Dr. Rebecca, you will take over, or I?
No, you'll take this.
Well, the question was that do you have hospital accreditation in your institution? And the majority of the people, 83%, say that yes, and 17 say no. I think it's very heartening to know that even in Asian countries, the majority, there's the awareness about accreditation is there, and most of the hospitals from where the viewership we have, they are accredited. And as we had stated earlier, there was a study that was quoted. They say that unless we have accreditation in the hospital, patient care services cannot improve. It's very much integral to patient care, safety of the patients in the hospital. So so accreditation is the way forward, because small settings, small resettings of the processes can lead to very positive gains. So this survey is quite satisfying to me. Over to you, Dr. Rebecca.
Thank you, Dr. Baljit. For those of you who've forgotten, please remember to close the poll question on your screen. Linda?
Okay, so now that you have heard all our speakers, I'm sure there are some questions in your mind. Again, send in your questions or comments via the Q&A section, and just text in your questions there, and we will direct the questions to the respective speakers. Rebecca?
Yes. When the senior anesthetist was about to draw the fentanyl, now this is a repeat of the case we have presented at the beginning of the session. So just listen carefully, because we're going to ask you questions on it. The senior anesthetist notes that the fentanyl vial is empty and the ondansetron vial is not yet opened, and that's full. There's a broken vial of fentanyl next to the ondansetron. After verification, the junior anesthetist does admit that he's given all of the fentanyl, mistakenly thinking it's ondansetron. But the surgery's gone well, though there is a drop of blood pressure and heart rate. And this was noted and managed very diligently by the team. The child survived, and nothing bad seemed to have happened. Now, this poll question, Dr. Arif will take.
Thank you, Dr. Linda. As you have read the case, according to the case, what incident had occurred or happened? Please choose one of the answer. The answer: potential harm event in 54%. The next is harmful event, 25%. Near miss event, 12%, and no harm event, 10%. As you notice in the case, a drug was given, but it was noted that there was no serious injury or serious event that occurred. Only a slight decrease of hemodynamic, but the drug was given. So actually, the incident, the type of incident is no harm event. It means that something has been given or something has been done to the patient, but there was no harm, no serious harm. If potential harm event, like I have mentioned, is something that might happen if it was not aborted or it was not noticed, but it was not given. That's the most answer that was given by the participant. So the no potential harm event is not in this case, because in this case something was done. A drug was given, but no harm was occurred, happened. While near miss event is something that was something that was actually given, like the something that was given but was noticed before the injection. So nothing was reached to the patient. That's the answer. So the right answer is no harm event. So we should know what occurred in our case if there's an incident or event has occurred to us. That's the question. Thank you. Maybe the next poll. In that case, should we report this event to the hospital administrator or just input in the patient medical record? So that no harm event should be reported, or just dismiss it because it's not a big problem? Choose your answer. Yes, most of us answer 65% make a formal report, but a third of the participants no need to report, but mentioned it in the medical record, and only 2% no need to report. This is something that Dr. Rebecca mentioned, that we are sometimes afraid if this goes to a legal aspect. But as all the other speakers mentioned, that every incident, even minor incidents, is something that we can learn from, something that can improve our quality of care, health care. So minor event like near miss or no harm should be reported. And I think the best is reported to the hospital administrator or department. So it would be a data that can be learned from, and maybe there are policy or regulation that can be made to improve or prevent further harm or further incidents. I think that's my comment for the question.
Okay, so now we're back online and we have a few questions to ask our speakers. But before we go there, could I just refer back to the question, to the poll question of Dr. Arif? Was it really a no harm event? Because some are asking, I think in one question, it would have been asked if we could it have been a potential harm event as well? Because it's quite difficult, really, it is difficult to define these events because it was given. So there is a potential.
Yeah.
Or do you
Yes.
think, do you define it as no harm because just because nothing happened?
According to the terminology of the events, like I mentioned, potential event is something that's potential can happen or occur, but it did not occur. It did not reach the patient. Like example, like I mentioned, some alike drug is stored in the same place by side by side. That's a potential problem if the person who take the ampoules or the drug didn't read the drug name. So if it's stored in another place, then it will prevent any harm. But if it's stored, it's a potential problem. But if someone notices this situation, then they can store in another place, then there's no harm. That's what's potential. So potential happen.
There is a question of the word potential and the meaning in English.
Yes.
Yes.
Correct.
When you say potential, when you talk about drugs being stored in the same place, it's if the wrong drug was picked up and given, there is a potential for harm. Here, they were just lucky that they got away with it. So there was
no
potential for harm, but no harm.
But no harm happened.
Yes.
So I
Okay,
think
that's
it's very fine line.
Yeah. Yeah, it's a tricky, very, very fine line.
Very
Okay.
tricky terminology.
Thank you for that, Dr. Arif. So I will go now to Angelina, if I may ask. One of the questions given is that how can interested people reach the education programs and courses? Are there any links that you can suggest to our audience right now?
There are, if you look at the internet, there are a lot of institutions, a lot of agencies that offer education courses on patient safety. And even there is a course for patient safety officers. One is the Institute for Healthcare Improvement, IHI. Okay.
Yes, thank you for that. Do we have any other suggestions? I think for us as anesthesiologists, the Anesthesia Patient Safety Foundation would help us a lot if we want to talk about patient safety. We want to learn more. That will help. Even ASA, all our organizations in anesthesia have patient safety resources incorporated into their websites. So, and now do we go to Dr. Oh, there's another question I forgot, Angelina. Before I leave you, I want to know if you can suggest a step ladder approach to becoming a patient safety officer if you are an anesthesiologist. What is the first thing that you think an anesthesiologist should do?
Help in the defining the culture of safety in the organization, and then encourage people to report incidents, near miss, adverse events, or anything. There is a lot of lists. There is a list of a lot of incidents that one can report. So that's show the institution or the organization that you're interested in patient safety.
Okay, thank you for that. Rebecca, what do you think? Just a buy-in, right? It should be a buy-in before anything else.
I think Dr. Xiao has been down that road before, so we should ask him. The patient
right, doctors.
Okay, well, I guess if to start off with, I think usually in departments that have a safety mechanism like a critical incident report systems, the patient officer may start some learnings in managing that system. Like, for example, then they will go through all the various aspects of, promoting reporting rates, analyzing the events, and then also learning how to implement solutions and monitor them. So this will be a good start. And of course, depending on the institution that you have, they are usually departments dedicated to patient and safety that, they could be late. For example, in our hospital, we have a patient safety lead that every department contribute people to be the hospital's patient safety leads representing the department. So such roles can also be stepping stones for them to move on to more experience concerning patient safety processes.
Well, thank you for that. I think that really getting involved and you have a buy-in, then you start getting involved because when you get involved, you start studying, right? So for me, that's really already a step ladder approach, starting to study the system and improvements. So do we have any other questions?
There is a question on
Rebecca,
finance.
yes.
Yes. There's a question to all the speakers. What are your opinions if the hospital asks if there is a financial advantage if we implement higher quality patient safety? Dr. Baljit, would you take this question? Because that your accreditation, is there a financial advantage given the improvement of quality is directly proportional to the cost? Do you think it's more expensive?
Yes, I think there is definite advantage. For the small amount of money that is spent in the process of patient safety, the rewards are too many. Just to give you an example, availability of soap. If the soap is made available at all the places wherever it is required, for hand washing, the person who is taking care of the patient will do hand washing. Now, if he doesn't do it, let's see the consequences. The healthcare worker doesn't wash his hands properly. Even if he uses disinfectant, so that's okay. But then by not washing hands, we are increasing the possibility of infection, cross-infection, or whatever infection. Now, what that infection leads to? It leads to increased amount of antibiotics that we push into the patient. The hospital stay of the patient is prolonged. And see, ultimately, we are treating less number of patients. So consider the cost involved in just providing soap solution at all the points wherever there is hand washing required. So a very small, I would say, investment in providing soap solution to all the places would lead to a tremendous gain. It's just one example. There are many other examples also where there is just small tweaking of the systems which leads to tremendous gains. The cost involved is much less and the gain is much more. Coming back to the same study which I had quoted, just a few seconds. The study that I quoted by Mate et al., they believe that even in the low income countries, this is essential that we implement these policies for patient safety, because that would lead to tremendous gain. Yeah, over to you.
Thank you. One of the questions which I had put forward earlier to Drs. Arif and Sia is that in some countries and some institutions, people are afraid to report because they don't see the big picture of it helping to improve the situation. They're only afraid of their necks being on the line, that they are going to be caught. And why did you do it? Like in this case, why didn't you check? Why did you give that fentanyl? Or maybe even if you write it down in the records, it's in black and white, will there be legal action taken against them? What would you do about that?
Is it to me?
Yes, Arif.
Okay,
Your country and then
yes, that's a situation. I think every place that situation is happening to all staff, afraid to report of the issue of legal aspect. So I mentioned in my slide, it's the role of the hospital administrator, the management, give an environment that show that there is no blaming, there is no shaming, but there is you contribute to the improvement of quality care in your hospital. So the role of the hospital is important, that they should support, show that the environment has no blaming, that what you report will help contribute to the quality care of the hospital.
Would it help, Dr. Sia, would it help if the reporting was anonymous?
Yes, actually, I think to address fear of reporting, it depends on what the fear is, and anonymity is important and sometimes often necessary to encourage reports. Of course, in certain hospitals, depending on the reporting data infrastructure, sometimes it is required to put down who you are. But anonymity is very important. It's helpful. But I think what is also more helpful is also is a cultural development, which is a very complex issue, which requires a multifaceted approach from leadership, from communications, messaging, and also demonstration and role modeling of what you actually do with any incidents, how you manage it, how you talk about learning and articulate those commitments frequently, and sharing of incidents by leadership, people in leadership will be very helpful in changing the perception of a blame, shame culture to one that is open to learning, open to change. But it's not a simple...
The patient safety officer also would come. You have a strong patient safety officer who will be a buffer between junior people who are worried and maybe the organization. Dr. Baljit wanted to say something.
Yeah, I just wanted to say that, just to quote our personal experience, when we had NABH accreditation, it was necessary for us to have the incident reporting system. We started it, we devised a form under which it was written the name. You know, whoever is reporting the incident must name. The reporting was very less. But what did we do next was we removed that name. And we found that suddenly the number of incident reports, started increasing. And that was for us to learn that it has to be anonymous rather than pinpointing a particular person. Even though we do not have the blame and shame culture, I mentioned you that it is not the person who is at fault. It is basically the system at fault. Here in this case also, the case that you had highlighted, it was a system failure more than the person failure. I'm not saying the person is not responsible, but it is a system that needs to be corrected rather than the person. Over to you.
There was one
yes.
question about, or one suggestion that this child had OSA and 2.5 micrograms. I'm sorry to whoever sent that. You're very right. But the case we presented was a made-up case. It was something we dreamt up and put up. It was not a real case where something happened.
Okay. Somebody also, just one, Dr. Hari. Somebody also mentioned that regarding reporting, that when they started with anonymous reporting, and after a while people became comfortable, they actually put it in. But the problem with anonymity is that sometimes it's very difficult to investigate the case because some details might be missing. Maybe that's one, because sometimes maybe it's difficult to do improvement plan if you can't investigate some of the cases, although there may be ways to find out, I think. Dr. Arif, you wanted to say something. Please go ahead. You're muted.
You're muted.
Sorry. I just want to ask Dr. Seo about this no blame culture. How did you experience or provide this improvement in no blame culture in your hospital? You have experience in this reporting, incidents reporting. Maybe you can share.
Okay, so in the hospital, the leadership has made it quite clear as a priority about safety. And then we had, for example, a campaign called "Speak Up for Safety," right? So people are trained to speak up for safety, and then we also teach Speak Up for Safety courses. But what it does is that it creates this environment and culture to message to everyone about all this subtle but important messaging about how we approach safety events, how we respond to them, and how we speak up. So it is a collection and constellation of activities from top downwards, and everyone has a role to play in creating and articulating this culture and building it. So it takes time, but it requires leadership because they need to steer this in that direction. And one could do various surveys over regular intervals to assess how the people in the institution actually feels about, a just culture, or whether it's just talk and not really true, which we did find there are differences in cohorts of professionals, depending on the culture that's dominant in the different areas. It is not uniform. So that's something to also think about, having a survey on that.
Yes, Angie.
Going back to the case, even if it were not a real case, no, but how I see it is that it is the reduction in blood pressure and heart rate by 20%. I consider that as injury, but it is an ameliorated adverse event. There is an adverse event, but ameliorated because even if it reached the patient, the subsequent potential severity was significantly reduced as a consequence, because they found it out and then they managed the case properly.
Thank you for sharing that with us. There is another comment in our box that said that I noticed that people are also more happy to report if they feel that something is done. This is very true. And it's very important to close the loop. And if anonymous reports, they're also difficult to get back to the person when improvement is taken. So not all improvement might be obvious at all. So this is also true. So there are a lot of things to consider when you think about anonymous reporting. Maybe eventually it becomes, you can start saying your name when you report something. Okay, so
Just
what
one more comment.
else?
If it is anonymous, it's an anonymous report. So legally, there is no one's name on it. but you would know, the safety officer would know when this occurred, where it occurred, and would be able to take action and then quietly get back to the people involved and have a sit down and discussion rather than make it a public to-do.
That's
So
right.
maybe there's pros and cons to all sides, I think.
Yes. But what is really important is having someone as a point person who can actually liaise between the people who had done, who have something to report, and to the leaders of the organization. But true governance is important. Okay, so we have one more poll question. Angie, would you like to go ahead?
So what are the qualities and duties of an anesthesia patient safety officer? So first, the ability, you may have more than one answer. The ability to identify safety threats and take prompt corrective actions. Second, education is in safety science is a prerequisite for the job. Third, time dedicated to patient safety work is distinct from clinical anesthesia work. Fourth, participate in root cause analysis of perioperative events. And fifth, conduct a survey to assess the safety culture of the hospital. So you have 30 seconds to answer. So we have ability to identify safety threats. The first has 81%, then followed by participate in root cause analysis, and then time dedicated to patient safety work. Oh, education in safety science is a prerequisite for the job. It's gets 71%. That is not a correct answer, because as I said in my talk, it might be a very nice prerequisite, no? An outstanding education in safety science. But what is more important is an unwavering interest in patient safety and the willingness to learn. So the second answer is not correct.
Okay. That's it for us then. That was the last poll question today. So let's go to, now that we are done, do you have any last words from anyone? Or we're good? I think our discussion went very well, I may say so, and we would like to thank everyone. And again, to our audience, if you want to learn more, you please go to our website. But before I forget, your certificate of attendance, do not fear. You will get your certificate of attendance, but this will be automatically generated and forwarded to those who submit the post-webinar survey. So this webinar survey will be emailed tomorrow, February 20 at 1700 hours Singapore time. So please ensure that you put your name correctly as well as your email address. And if you want to learn again, learn more, know more, please visit our website, look us up in Facebook or on YouTube.
There are a lot more happenings in ASPA, and we believe that we empower each of our people through education. ASPA is a non-profit organization. Its mission is to foster the highest standard of pediatric anesthesia care in Asia. Hence, we seek your help to donate and help us in our cause. Please scan this and donate. Donate whatever you can towards education in ASPA. There's more. There's the Korean Asian Society, which is hosting the next ASPA meeting, ASPA 2023 in Seoul. Keep those dates free, 16th to 18th June 2023. More news. ASPA Cardiac SIG has its inaugural forum on 11th March 2023. Keep that date free as well, especially for those of you who are interested in doing cardiac anesthesia in children. And the next webinar is to be the basic principles of TIVA in children. There'll be case-based discussions, and we'll have some very, very interesting talks. So keep 19th March free. That's next month, 2023, 19th March. Thank you.
Thank you, everyone. Thank you for joining our webinar today. We really had a very good and interesting discussion. We hope to see you in the next webinar. Thank you and have a good day.
Thank you. Bye.